Welcome back to Just a Sharp Scratch. Today I'm joined by Charlie Craig, Assistant Professor at Coventry University, who's been in the forefront of nursing associate education and support since 2019. Charlie has worked with multiple universities to set up the nursing associate apprenticeships, co-authored the clinical pocket reference for nursing associates, and is passionate about raising this profile of this role. Charlie, it's great to have you on the show.
Thank you for having me.
Oh, no, it's absolutely our pleasure. But before we get into your kind of interrogation session, we kind of get all of our guests to come on and give us a number between 1 and 200. We're going to have to probably increase that at some point, just so that we can give you a random icebreaker question, just to kind of make things a little bit more lighthearted. So can you give me a number between 1 and 200?
Give you 1 and 200. Do you know what? I'm going to be really soppy and sentimental. I'm going to go for the 30 because that's the date I got married on.
Ah, lovely. Right. So your question, if I find a number 30, is, wow, I've managed to make this one a bit more interesting. So if the nursing associate role had a mascot, what would it be and why?
Would it be and why?
That's a good one.
That's a really good one. There's lots that spring to mind of things that I'd like it to be.
We'll go for that.
Yeah. Do you know what? I'm going to go for one. It's along the lines of, I was thinking of a lion, but actually, do you know what? I'm going to go for Tigger.
Tigger.
Because
bouncing
full
around.
Of energy, bouncing around, full of energy, absolutely wanting to do their best for everybody, make everybody happy. Just, Tiggers make me happy, or Tigger, I should say. There is only one, of course.
Exactly.
And I
the
think,
only one.
There is only one nursing associate role, and we really need to push that forward.
And that's the wonderful thing about Tiggers.
It is the wonderful thing about Tiggers.
Definitely. And I think if I had to answer it, for me, the first thing that popped into my head was probably guinea pig. I think because right at the beginning of the role, we did class ourselves as guinea pigs. And I know lots of people didn't really want us to, but all I can remember is when we qualified when the register and stuff was opened in 2019, a lady who was on the same pioneering course as us, as we were classed as guinea pigs, actually got a guinea pig tattoo of her, this guinea pig in all full robes of qualifying in 2019.
Fantastic.
And I thought to myself, God, I wish I had that idea. That would have been brilliant. So
that is a really, really good one, because actually, yes. And you were guinea pigs, for want of a better word. I'll hold my hand up. I've been a guinea pig. I was the first cohort through Birmingham University on their degree programme. So I get what that's like, although nursing was established. But yeah, you were. And I like to call you trailblazers, the first guys through. I think as much, you're guinea pigs, but you're trailblazers.
Very, very much so. And I think, it's great to be able to be part of that. And you never know. I still might get my tattoo. Don't know when. It might have to be just a sharp scratch one. Maybe if we get so many thousand followers, I'll get it tattooed somewhere. But
we're going to send that one out there then.
Oh, there
Martyn
we go.
has said, if I get this number of followers,
we'll put a
I'll
number.
Get a tattoo.
Yeah, we'll get it tattooed somewhere. We won't say where. But anyway, right, let's crack on with the show. Right. So my first question really is kind of, let's start for a bit about you. Can you introduce yourself and share your journey of how you kind of got into nursing and education?
Yeah. So I've got some pictures. Shall I show you my?
Go for it.
I don't know if I can share the screen. How do I share the screen on there? That's going to be interesting. I don't think I can. Oh yes, I can. There we go.
Oh, can you? Oh,
I can. Share screen. You're going to let me share it.
So this is new for me.
Yeah, that's what you get for being a lecturer, isn't it? Okay.
Look at this.
I'd say typical little girly. I am obviously the one in the nurse's uniform. I am not the one in the other uniform. Do you know who that is? But I won't name her on here. I had the nurse's uniform. Typical little girl. That said, I never ever had any ambition to be a nurse whatsoever.
Really?
I come from a family of Navy doctors and nurses, and it was very much do you know what, I'm never going to do this. I don't want anything to do with nursing. And at 16, what I wanted to do was to go off to the Tom Maria School of Cooking, and I had it all. I got the application, I got all the information through, and my parents just went no. And because I grew up in an era where your parents went to no, you didn't do it.
Yep.
No, your brothers did A levels, you're doing A levels. And so I was locked into doing A levels. And so I really didn't know what I wanted to do. And I suppose I was sort of getting to the end of my, what was lower sixth, and this is aging me somewhat, year 12. Getting to the end of year 12 thinking, I have no idea what I want to do. My mum was a nurse, and so I just did that. Mum's a nurse. I like people. I'll go into nursing. My headmistress at the time was so disappointed with me. You know, in her view, nursing was a second-rate career. You didn't do nursing. It was just
Really?
like, yeah, oh yes, you go to university, you do a degree that means something. So you go and you do engineering or being a doctor. So anyway, when I said to her I actually want to do this through the university, she started smiling again. Yeah, that's okay. I'm planning to go to university, which I think is really sad. And it was sort of taking
Yeah.
away from the nursing career at that time, especially when I trained at a time where we had sort of 3 levels of training, if you like. We had your, what people call now the old style RGN training through the hospitals, schools of nursing. You then had Project 2000. And then you had the degree emerging, and some universities had it running for a while, others weren't established. And so every school of nursing I applied to was like, yeah, great, we're stopping it next year and moving to Project 2000. I'm like, going, I really don't want to be tail end Charlie of a course going through. I'm going to get forgotten. Everyone's going to be concentrating on the new program. So I thought, I don't like Project 2000. Loads of stuff about it, and I'm sure lots of the listeners will know what I mean when I said did not want to do Project 2000. So the only other option was to go through the degree route. I really wanted to do children's nursing, so I sort of researched where I could go, and I ended up with Birmingham University. So that's actually the second picture, sort of top right. That's me graduating. It's graduation season, isn't it? That's
It
my
is.
lovely mum with me. I spent 4 years, because back then it was 4 years, and they had set the course up very much in lines with Project 2000. So we did 2 years of general nursing. So I did sort of the primary care community work in the first year, and then in the second year I experienced children's mental health and learning disabilities. Great introduction to nursing. I was like, yeah, I'll specialise. I'm going to do my children's nursing now. And then halfway through year 2, they went, no, you can't. We haven't validated the programme. Great. Here's your 3 options. You can leave permanently. You can take a year out and come back next year when hopefully we'll have it validated. They didn't, newsflash. Or you can transfer, go to a different sort of school of nursing. And we looked at Oxford Brookes, and they had the paediatric course. I could have transferred over, but I was going to be one of 4. I was going to be the 5th one of, there was 4 there. And I was there doing the mass gain. You know, I'm one of 35 at the moment. It's really small. It's quite cliquey. We are a small group. If I'm breaking from that to one of 4, it's a bit of a nightmare. I'm not going to know anyone. They're going to have gelled for 2 years. So I chose to stay at Birmingham, and I trained as an adult nurse. I qualified in 94. The university is debating about us. Apparently we don't exist. They think their first cohort started in 1991, and we didn't. We started in 1990, and we keep trying to say, no, honestly, we're here. Look, there we are, graduating.
Yeah.
We've been 31 years this year. Long time. So yeah, so that was sort of my entry into nursing, and then it was
a very rocky start.
Rocky start. What do? I want a job. I'd worked at the Queen Elizabeth in Birmingham during my training. Worked in cardiovascular, absolutely loved it. Really wanted to do cardiovascular. Fantastic, really exciting. They loved me. We never had a single cardiac arrest when I was on shift. As a student, I was like, oh, I really want to experience this. I want that adrenaline. I want to know what it's like, get the cholesterol, all of this. No, nothing. Never had a single cardiac arrest. So they loved it. But they did say, we've got jobs coming up. Would you like to apply for one of them? Yeah, brilliant, excellent. The hospital went, no, we don't want the university students applying for our jobs. So yeah, it all went up, it all went through, the powers to be, RCN got involved, all of this. And I eventually got a telephone call in the October. I'd graduated, qualified in the August, got a telephone call in the October. And it was the sister on the ward saying, they've agreed it. Could you apply? And I went, I'll start work tomorrow. And that is me in the bottom left-hand picture. I started work at a lovely, wonderful place called the Rowans Hospice, independent hospice. I started my career, instead of cardiovascular, nice and high tech and everything. I actually started an end of life, and I loved every minute of it. It is absolutely fantastic. You know, if I was to look at all the nursing that I've done, do you know what? It's absolutely proper basic nursing. Certainly was 30 years ago. So I think it's a bit more high tech now. But it was, you know, you had that time to sit with a patient and talk to them and get to know them, get to know their family. You did the nursing care for them, and you did everything for them. And we were very fortunate because we had a very visionary consultant who was absolutely wonderful and completely believed in nursing as a career and as a role, and just went, you know the patients better than me. If you think they need more pain relief, let's give them more pain relief. It was just a lovely place to be. So I did that for a few years and sort of worked my way around, went to a few other places. I did a Macmillan unit at a lovely hospital called King Edward VII Hospital in Midhurst. Doesn't exist anymore. Sadly, it's now sort of private housing. And I worked for Marie Curie as well. So I had sort of the whole remit of independent hospice, Macmillan, Marie Curie. I did do a spell at a local oncology unit when I was at the Rowans as well in Portsmouth. So I was thinking, oh, this is where I'm going. It's where I'm heading. I then sort of met my first husband and got married and started having children, and sort of thinking, okay, maybe this isn't where it's going. I went back after my first one, and I sort of paid back my maternity leave, having worked at the Royal Marsden while I was pregnant, and went to the Rose to pay back the maternity leave because my then husband was in Ireland. And I just like, I can't do this anymore. I can't be present 100% for my patients, because actually there's quite a big chunk of my brain that is sitting with my 6-month-old baby that we've had to drop at nursery. And I just like, I can't do this. And I always said the moment I couldn't fully engage with it and couldn't give 100%, that was the day I was going to step away from end of life, because I think you do need to be present in that moment, because you've got to be there for your patients. You couldn't have your brain thinking about your baby crying because you left home. For them, that's, you know, they're thinking you're never coming back. So I had a break from nursing and sort of had 2 children, and then thought I really want to go back, and went back and worked for a sort of a day hospital for the elderly. If I say I worked at the Gosport War Memorial, people might have heard of that name. Thing is, it is on the NMC site.
Yeah.
It was a really interesting time. I really enjoyed it. I never thought I really wanted to work in elderly care, but working in a day hospital was really enjoyable, and I did learn lots of skills that I hadn't got at that point. I sort of then ended up having another 2 children somehow. So sort of moved away and had a bit of a break, and actually went and worked in the nursery for a while. I really don't recommend it to anybody. You know, working with 2-year-olds is it's great when they're your own. Working with lots of other people's 2-year-olds is never quite so much fun.
It's a tough job. That's my wife's job, funnily enough. That's what she does.
Take my hat
even
off to
I'm
her.
like, oh, I couldn't do that. No, give me a patient that's throwing, you know, feces at me and stuff like that anytime.
Yeah.
Compared to yeah.
I completely agree. I've been there. I've got the T-shirt. You know
So
what? My own are lovely.
Yeah.
I do not want anyone else's anymore. So yeah, so I did stay there. It was convenient. That was why I did it. But it still wasn't what I really wanted to do. I still had that love of actually wanting to work with children. So an opportunity came up. I was in Portsmouth at the time, and an opportunity came up to take a job with the school nursing team. And I started in the May. Had a very, very good head of the Children and Family Service who cottoned on very quickly that I did not wish to stay where I was on that, and put me onto the Masters for the Specialist Community Public Health Nursing. And that's my graduation is the bottom right. And that is my 2 oldest. They will probably not like me very much for putting it up, but I'm really proud of what I achieved, and I'm really proud of them. So, you know, it was a long slog. I started my degree in 2008, my master's degree in 2008, and I finished the actual sort of PG qualification bit in 2009. I didn't get my master's until 2013-14, because like with a lot of mature students, I had to take a break from learning, and I had to step away, do the job, look after my family. Within that time as well, towards the end of it, I'd had my marriage break up. And so sort of at that point, I'm like, okay, what am I going to do? I'd sort of was working in school nursing. I then worked in social care for a very brief spell. I hasten to say it was really brief. But I worked with a transition team for learning disabilities. Lovely insight, gave me lots of sort of good knowledge about working with people with learning disabilities. But I couldn't stay there. It wasn't feasible. I was traveling. I was out for 12 hours a day, and with 4 children, it just wasn't happening.
Yeah.
So I happened to be in the right place at the right time. And Southampton University were looking for a school nurse lead. And so I became the school nurse lead. And that was my, if you like, my foray into education. And that's where it started. So I worked with them for a few years. I then moved away from the area up to Wiltshire, was a team leader back with public health for a year. When I really miss education, I really want to go back to it. I got talking to somebody at local college who was wanting to push, funnily enough, the nursing associate program, and was asked me to come on board. And so I got a job with them as one of their lecturers in health and social care, on the understanding that I was going to be working with them to push the nursing associate role. Sadly, that didn't happen. The person who'd take me on board went off sick, and they never really got the ball rolling. And a bit like nursery education, further education is not really for me, is all I'll say. But I kept looking and I kept looking, and this job came up at Oxford Brookes, and it was to work with the nursing associate team. And I jumped. I really thought, yes, this is where I want to be. This is new. It's exciting. It's so needed. You know, nursing as a profession, we're on our knees, as you know. We need that support. And the nursing associates, I believe, are the ideal people to provide that. So that's where I started with nursing associates. And so from 2019, I've sort of been in various roles at universities, and now sort of based with Coventry. I'm not sadly working with the nursing associates at the moment. I'm working on the master's adult pre-reg program, but I am external examiner for 2 other universities on their nursing associate program. So I'm sort of keeping my hand in, and I work with, sort of help support another colleague who is developing a program, another university. So yeah. So that's my long-winded story of my entry into nursing, where we are
Into
now.
nursing and into the nursing associate role back in 2008. So how widely known was the role back then compared to?
I don't think it was that well known at all. I think, you know, you would say nursing associate to people, and I know you will have heard it countless times, and people go, "Do you mean an enrolled nurse?" It's like, no, I don't mean an enrolled nurse at all. I mean a nursing associate. Yes, you know, if we're honest, there are similarities. I don't think that's a bad thing. If I think back to my training, I learnt more from some of the enrolled nurses that I worked with on the wards than I ever did from the staff nurses, because they had the time, they had the knowledge, and they had the skill, because they had been on that ward and in that role for years. But I learnt my aseptic technique off a fantastic enrolled nurse on a urology ward. And to really date myself, we did our aseptic technique with tweezers. So we didn't have clean hand, dirty hand, or any of that sort of nonsense that
Yeah.
people have talked about in the past. We had tweezers.
Wow.
So it was really interesting.
One of the things, you helped set up the NA apprenticeship at multiple universities. So what were some of the kind of biggest challenges that you faced during that process?
So if I start with Oxford Brookes was already established because they were one of the pilot programs. So I joined just as we were going through validation with the NMC. So that was really good. And so these are my people. You can edit that bit out.
Outtakes.
Yeah, thank you.
Do you want me to do the question again?
No, I've got the question. So I think with Brookes, the biggest challenge we faced there was COVID, which came, you know, not long after we'd started validating the NA program, you know, 2019 into 2020. 2020, there we are, universities are closing. And we didn't want to just go, here's a PowerPoint, we'll put the PowerPoint up, you can look at the PowerPoint, we'll talk at you for 3 hours, we're going to lose people. It's death by PowerPoint is bad enough when you're sitting in the room. Sitting online, it's even worse. So we transitioned the whole program to an online flipped classroom approach. I will hold my hands up and go, do you know what? During COVID, I probably have worked harder than I have ever worked because it was nonstop, because we were constantly rewriting, recording. We set it up at the time, and they probably still do actually. Brooks used Moodle as their platform. So we were developing Moodle books. It'd probably be in H5P now if we were doing it now, but 5 years ago it was Moodle books. And we were transferring everything into a format that was accessible, that people could look at, they could play a chapter, they could do some work on it, they could go away. And the idea was that they would work through the middle book in the morning, or sort of half the morning, and then we would have some time together to go through any questions. It wasn't about reteaching what they'd already done.
Yeah.
It was about, let's, what have you learned? What have you got from this session? So it was intense, to say the least. We managed it, and I think we developed quite a good program considering the circumstances we were under. Certainly the students seemed to appreciate it. We hit lots of complexities because obviously nursing associates, one, it's an apprenticeship, and two, it's in healthcare. We know we've got a disproportionately more people who work in healthcare with additional learning needs to other professions. But within apprenticeships, there's even higher numbers of people with additional learning needs. So we really had to be mindful of how we're going to work that so that it was accessible. And it wasn't just accessible to some of the course, some of the cohort, it was accessible to everybody. So we worked really closely with the education team, and we made sure that our slides and our PowerPoints were transferring to video and that they were easy to read. We made sure we had transcripts with everything. Got loads of different formats and stuff. We developed some maths programs while we were there. That was great fun. I learned how to do the lattice method of multiplication. I'd heard of box, never heard of lattice till that point. But
No,
it's I can show you, but it would take time because I'd have to remind myself how to do it. But we did, and we ended up, I think, with really quite a good program. And we stayed online for quite a while because students were quite nervous about coming back after COVID. So even in 21, 22, when lots of universities were going, no, we're going to be fully back, we were still mindful that we had cohort of students that are actually public facing. They are out, they're working on wards, they're working in areas of high COVID. And we had other students who were working with vulnerable people because they were coming from nursing homes. And we didn't want to be, the ones that caused somebody to go back out to work or go back home where they had a vulnerable person and sort of take COVID with them. So we did keep online probably longer than other places. But yeah, so that was sort of the COVID time. When I was at Chichester and other people that I've talked to and I've supported, it's that complexity of the apprenticeship and actually getting people to understand it, and getting employers in particular to understand what is required of a nursing associate apprenticeship, because it's not an adult program.
Yeah.
And I think that's the thing that really, really frustrates me about it, is people see it as another adult nursing program, and it isn't. It's generic. The idea is you can come out from a nursing associate program as a nursing associate and walk into any of the 4 fields and get a job. I don't think it works like that.
And do you think that's what kind of like educators and employers still kind of get wrong about the NA role, that they still think as though it's something that they can't?
I think there's a lot of places that are still, because we have, adult nursing, if we face it, adult nursing is the biggest number. Whether we're looking at nurses or nursing associates, that is where the biggest number is. And so people get very focused on that. And certainly when I was at Brooks, we did, and we got some of the children's content in. In fact, my co-author is a children's nurse. And so she was very pro sort of, let's get the children's content, let's push that. But we had to be constantly thinking, well, what about the mental health? What about the learning disability? And it can't just be a token lecture here or there. It's actually got to be weaved throughout the program. It's got to be brought into everything that we're talking about, because actually, yes, as we might have nursing associates working in an adult environment, but actually they are ideally situated to work with those patients who are coming in who have a mental health need or have a learning disability, because they've had that training. So it's got to be more than just a one-off lecture about this is learning disabilities, this is what it is, No, it's got to be weaved through. And how do we work with a patient who comes in? How are they going to present if they come into A&E? What are they going to present? Pain. It's different. They'll present differently with their pain. They'll talk about their behaviours and how they've changed. And the same with mental health. You can't just ignore that side of it.
I agree with you, because I think it's very much that we have to have this multi kind of discipline in ourselves of being how to deal with patients. Not every patient is going to be the same. And for me, I was lucky when I did my training. I came from a CAMS background, so that was where I was doing my nursing associate role. So I had this fantastic experience of mental health and support and training through there. To which then, when I did the nursing associate course, it was very much, I felt quite clinical. It was more rather than mental health and stuff like that in general. And to hear that the fact that you were like weaving this in is fantastic, because you are going to get those patients now when you're working in A&E that come in presenting with mental health, and you're being able to kind of look at being able to support them or diffuse the situation because you've learned how to do those kind of skills, I think is what's needed in probably all healthcare, not just specifically
Yeah. No,
nursing
I agree.
associates.
Absolutely agree. I mean, I think back to when I trained, and my mother would say the same. She's even older than me, obviously. She's an SRN, so she's a state registered nurse, but she will still talk about she did a placement in mental health and the experience, and you remember that, and you can take that through and say, I'm just so grateful that I did do the training I did, because I had those experiences. I worked in learning disabilities. And so I had to understand. I had to understand about Makaton and what that means and how good that can be to communicate with a patient with a learning disability, because that's their language. And with mental health, and I had a great time. We had a mental health hospital in Birmingham. I wouldn't know if it was still there, in Dudley. And, it was great to actually go and get that experience and be able to take that back into sort of my world as an adult. And I just think, those experiences stay with us. And it's a bit like working in social care. I learned a lot about communicating with somebody with a learning disability. I also learned a huge amount about adult social care and about adult safeguarding, and how it was nowhere near as robust as children's safeguarding, and it still isn't as robust. But it was really valuable, because actually now I can talk from having worked with adult safeguarding, not just this is what I've read in a book. I've actually worked with that and can actually bring that into sessions. So it
Yeah.
is, that experiential learning, which is so, so important.
And you kind of created your own little kind of pocket reference to of different areas and stuff like that, because it leads me perfectly on to this little book here that we are going to be talking about now. So this
Yeah,
is something really, really
baby.
exciting, and I'm so privileged that you guys have been able to create that, and for us to be able to give a few copies away to our fellow listeners and student nursing associates. So like I said, we're going to talk about the clinical pocket reference for nursing associates. So what inspired you to kind of like co-create this, and how is this received when it was launched?
So, if I'm honest, this came from the publisher. So they wanted a clinical pocket reference book to match. Have I got it? I haven't got it to hand, but
Here's one I
to
made
match these
earlier.
ones. Yeah, here's
Yeah.
one. It's not. That's everything falling on the floor. It's not this is the children's one. But they wanted something like this to match nursing associates. And I got asked if I would be interested, because they have a good relationship with Oxford Brookes, and that's where I was at the time. And I was asked if I would be interested, and did I know anyone else? And so I brought my colleague Laura on, who, as I say, she's a children's nurse. So I thought, this is great, because I can do all the safeguarding stuff, and that's fine. But I'm not a children's nurse. I don't want to take that responsibility of, writing about observations for children, because actually that's not my speciality. So we work quite closely together, and actually had some really, really good fun. The publisher's pen was brilliant, because they'd started with this idea, and we ended up with this idea. And they were absolutely fantastic, because when we looked at it, we said, well, that's really good, but you can't get we did look at doing this format, but it was going to be twice the thickness and not really pocket size. And we said, you can't. This is, we're talking about a role that is 4 fields. We can't just give them the adult. We wanted to write something that was thinking about that accessibility. If you look at a standard nursing textbook, the language in it is complex. It's not always understandable. I mean, I picked them up, and I'm quite careful about the textbooks I choose to use when I'm teaching, because I think they need to be something that's understandable. It's textbooks that have been written by somebody who is, they've got a doctorate or they're a medical professional. Doesn't work for a nursing associate. So we wanted something that was really written purely for them. It's not written for anyone else. There's no other role in mind. We haven't got the the assistant practitioners. We haven't thought about any of that. Purely for nursing associates. And so we said, it's fine, we'll do this, but we really want to encompass the adult, the child, the mental health, the learning disability, hence the lovely signpost on the front.
The Thorfields.
And I'd say they were absolutely fantastic, and they really worked with us and said, yeah, okay, let's go with this. We wrote reams, they cut it back. We wrote more, they cut it back. But we did, and we really honed it down. We wanted to make sure that things like, again, there's a lot of adult stuff in there. That's because adult population, 18 to 65 for sort of adulthood, and then obviously we've got the elderly. It is a big part of the population, so we can't ignore that. So yes, there is a lot of adult content in there, but we wanted to make sure that you had the children's, that we weaved mental health. We wanted a chapter about mental health. We wanted something about the Mental Capacity Act because it's so important to understand. We wanted something about safeguarding, and not just adults, it had to be children as well. We wanted end of life to think about children and mental health and learning disabilities. There's a chapter on learning disabilities. We wanted to make sure that somebody who was training as a nursing associate, who was coming from a learning disabilities background, could pick this up and it would mean something to them. It wasn't just another textbook. Yeah, I think that's certainly what drove it. Make sure that I've not missed anything, because Laura gave me some notes and she went, well, say this as well.
But the one thing I do want to say about this book is, obviously, like I said, we were the pioneers, and there were lots of nursing associate books being created whilst we were kind of even still learning and still going back in 2017 and stuff. I can remember books still coming out about the nursing associate role and telling us what we can do and what we can't do, even though we didn't know ourselves. And like I said, they were written by nurses for nursing associates. And I feel with this book, it's very much that it is the knowledge that we need. It's written in our terms, in our texts, and our understanding. It isn't written for a nurse. Like I said, it is written for a nurse. So it's the jargon and stuff that you got in here. And even I myself, like I said, I don't really work. I work in mental health in the sense of in my general practice, but I don't work in the mental health field as I used to in CAMS and stuff like that. But reading through that, I was like, wow, yeah, this is really good. I wish I had this a bit more, so I could understand and even go back and show nurses and go, look, this is what I can do. This is what I'm doing. And I think, yeah, it's great to have this this pocket reference guide. So yeah, so it's very good. So.
No, well, thank you. We did speak to our students and we said, look, what would you want? What do you want? And that's, some of that information has fed into what we developed, because, there's no point us writing a book without actually finding out what you need. And I'm really, really pleased to hear what you're saying about it, because actually that was the whole intention, was to write something that was for nursing associates, and recognizing that a nursing associate student is not a registered nurse student. Now, that's not to say that they don't go on and they don't train and they don't become registered nurses, but when you start that training, you're coming at it from a very different point. And we wanted that acknowledgement that this is written for you for it to be accessible to you. This isn't for a registered nurse, although actually first year nurses, even second year nurses, valuable for them.
Yeah. And the one thing I do want to say is, I know I'm plugging this book. I'm not being paid for this. You guys aren't paying me millions of pounds. The Lamborghini still isn't sat on the driveway. It's just because, like I said, I truly, truly believe in it, and I think it's a great resource for all student nurses and even registered nursing associates still to have to kind of refresh, especially if you're thinking of changing your field. Like I said, if you are working in mental health and then want to go to children's or adults, because that's what's great about this role, that it said it can adapt and mold into different areas. So if anyone is listening and who wants a copy, where's the best place that they can find it?
So the best place to go, there are various places. You can get it on Amazon, absolutely, or you can go to the Clinical Pocket Reference website. You've got the physical book, as you say, we've both got copies. It's great. I love a physical book. I like being able to flick through. As you can see, I've got it all marked, all my chapters. I like just being able to hold a textbook, but not everybody does. And they do have a downloadable version. Have you seen the downloadable version?
I have indeed, yes, because
Yes.
I do know that there is a little bit of an offer that we're giving away to all our fellow listeners. So if they do go on the clinicalpocketreference.com and select your format, which either can be the print, the ebook, or the bundle, which saves you an extra £4. But if you enter in the code JAST25 at checkout, it'll help get you some discount there. So, but we'll put the link and stuff in our bio and stuff like that to where to go.
Lovely.
But I think it's definitely one to read.
Yes, I obviously I've got the download link, and I love it because I pull it up in lectures, and I've actually pulled it up in lectures with nursing associates, but also with student nurses, and I've gone, look, this is what I mean, and I can show them, and I have to do it on my phone, unfortunately, but but it works on your phone. It is set up to work on your phone, and you can get clear pictures. So it is, yeah.
Yeah,
We love it.
No,
And
I do.
pleased
I've
they
downloaded
do.
it on my phone. So yes, no,
Yeah.
definitely check it out. Looking ahead, what's the kind of long-term potential of nursing associate role in shaping the kind of nursing workforce?
I mean, I firmly believe that nursing associates should be here to stay, and that's what I would be pushing for. I think we do need a scope of practice for you. I think that's absolutely critical, because as a registered nurse, could train in Birmingham, I could have gone and got a job in Nottingham, I could have got a job in Portsmouth, I could have gone to Cambridge, I could have gone to Wales. My scope of practice as a newly qualified registered nurse on a cardiovascular ward would have been pretty much the same wherever I went. As a nursing associate, you don't even have to move massively in your area. You can go from your acute trust to your primary care trust, and your roles are suddenly massively different. Your acute trust might go, no, you can't give insulin. Primary care trust says, of course you can, because you've got to go out and visit people at home. You need to give insulin. Having a really firm scope of practice, I think is going to really help drive that role home, because one of the biggest issues with the nursing associate role is that people don't understand it. Even now, people don't understand it. Nurses, registered nurses, don't get what it is you can do. They don't understand that you are trained, you're a registrant, you can go and do drugs, you can go and do a wound dressing because actually you've been trained to. I remember having a conversation with somebody from one of the trusts when I was at Brooks, and they were talking about, oh no, but nursing associates don't assess. No, they don't do an initial assessment. But what do you think a reassessment is? Because actually nursing associates do reassess. It's reassess and monitor. You can't monitor somebody without reassessing them. You can't say this person's deteriorating if you haven't assessed them. So I think people get very fixated on can't do an initial assessment, so you can't assess. Well, actually, no, that you can't do the initial assessment because that's about planning care. But you can monitor and you can discuss changes in that care plan, and you need to know how to do that. So scopes of practice, very definitely. And I think, actually, it's going to sound really awful, but as registered nurses, we need to sort of get off the horse a bit and just sort of our high horses and go, oh no, we don't. We can't hold on to everything.
No.
If we look,
holding
when
on
I
to
trained,
those reins, isn't it? That's the problem.
Yeah.
Being able to let go a little bit.
Yeah. Well, I mean, when I trained 30 years ago, and I quite often use this as an example, so, everything that we really expect nurses to do now was add-on training. So you didn't come out qualified to do an ECG. You didn't come qualified to take blood. You didn't come out qualified to do, or well, if you don't with IVs now, but a lot of it was add-on training that we did after we'd actually qualified and we were registered. Nurses now are expected to come out and do so much. They're expected to come out and be a supervisor, to be a practice assessor without really having that knowledge. If we're expecting registered nurses to do that much more, and of course we have got the advanced practitioner roles as well, we are doing much, much more complex care than we ever used to. We're taking off from, I want to say junior doctors, they're not junior doctors now, they're residents, I know. We're moving to the American terminology. We're taking from their role, and as nurses, we're now doing things that were traditionally always done by doctors. So, something has to give. We can't hold on at both ends. If we as a profession want to keep progressing, keep growing, keep developing, keep getting our professional status recognized and respected, we've actually got to drop off at the other end and go, we have this really good body of nursing associates that are trained, they're registered, They are monitored by the NMC in the same way that I am as a registered nurse. Actually, they can take on what we can't do anymore. And I think, we've got to start moving to that frame set. It's about thinking about having a sort of like a trickle down approach. So we're doing more and more at the other end as a registered nurse, and actually we need the nursing associates to be taking on more and more. And we also need to be moving it away, some of it away from the healthcare assistant role and moving it back into that registrant role. And I'm not denigrating HCA, so please don't all jump up and down and shout at me. What I'm meaning by that is that, yes, we can give HCAs the skills, but it's that knowledge and those behaviours that are really, really important to understand what it is you're seeing, what you're evaluating. We're taking on more and more as a sort of the registered nurse at this end of it. So we've got to drop off at this end. So the nursing associates coming up and taking that. But also, and I was going to say, please don't anyone jump down my throat. I'm not denigrating the HCA role at all. It's a really valuable role. But we need to start moving some of the sort of the role that they're doing and start moving it back into where it had always used to sit, which was with the nursing role. And the nursing associates taking that back up. Now, Laura gave me an absolutely brilliant example of this the other day. And she was talking about how she was doing a progress review with one of her student nursing associates. And they were talking about how they had done an ECG and they'd recognized the ECG. They was looking at it, they're looking at sort of all of the readings. Sort of, okay, so they knew to escalate. Their knowledge and behaviours that they got through training meant that they had the awareness that this was urgent, this needs to be escalated, I can't leave it. She made that distinction between her as an SNA and her as an HCA. And she said, as an HCA, I wouldn't have realised. I'd have just done the ECG and I'd have put it down on the pile. And I think that's really important. And I remember training, and actually, no, I wasn't training. I tell a lie. It was when I was working in the daycare hospital and having, sort of HCAs who were doing blood pressures. I picked up a chart and they went, but why didn't you tell me? Because the blood pressure had rocketed. And they hadn't thought to raise that. Now, I am not saying HCAs don't think, and there aren't those that don't raise it, but actually, guys, they're the ones that need to then go, I'm going to become a nursing associate. They're the ones that need to develop those skills. So we need to move much more back to that, actually. Stop thinking of sort of the HCA role as it was with the very basic nursing is actually not an important role. It's essential role, that basic nursing, the washing, the dressing, feeding. I tell nurses and nursing students, you do this. You don't ever say you're not going to do that. And I have sadly met student nurses who go, why am I washing a patient? You're washing a patient because you're assessing while you're washing. Nursing associates washing a patient, they're assessing. I'm not saying HCAs don't look, but it's a different role. And we've actually got to start getting that differentiation between what is coming under the registered professional. And I'm putting nursing associates in that as well, because I think the nursing associate has got so much value. They are doing those skills, and they're doing that sort of the basic end of the nursing, and they're the ones that are going, actually, this is really complex. This is going wrong. We need to raise this. We need to alert. I've had nursing associates who have, as students, have been out to visit patients and have been calling in because they've got sepsis. As an HCA, they may not have recognised that.
No, you're right, and it is very much that even with myself when I was a support worker in HCA, you very much task orientated, and I've spoken about it before in other previous podcasts where, when I first came onto this course, I was quite arrogant, I have to admit, because I thought, well, I've been in the NHS for over 8 years. I've been a HCA. I kind of know what I'm doing. Why can't I just be a nursing associate straight away type thing? And it wasn't until I started doing the training and started learning about, evidence-based practice and why you make these decisions and why you do the things that you do, that my brain and pattern now and thinking pattern is completely changed. And I can't ever go back into the HCA role and thinking in that anymore, because it isn't. And like you said about the person looking at an ECG, even myself, I looked at this and went, that doesn't seem right. This doesn't seem normal. And going to escalate it. So I did. And then it found that the patient was in AF because I could tell this isn't right. So then off the hospital they go. And it wasn't, if I just left that in that tray, it might not have been seen for a couple of days because obviously the doctor gets to go through it and the paperwork and stuff like that. So yeah, it's those little things that will kind of show that, you are doing a little bit of an assessment. And I think we sometimes get stuck on the words. I think that's the problem as well, because when you think about an assessment tool like NHS 111, when you ring them up, they're going through an assessment tool. They're not a trained professional on the telephone. So why can't nursing associates in certain areas have an assessment tool that they follow that's been signed off, that if they tick all these boxes and go for this scenario, this is where we end up. This is where I need to go with this patient. And I think sometimes this is what we're kind of getting stuck on is that word assessment and literally just going blank no, blank no.
And I think you're right. And that's one of the things we wanted to make really clear. And I'm sorry to go back to the book on that one, but it's why chapter 1 is monitoring the deteriorating patient, because you do monitor. That is part of the NA role. That is in the standards. You monitor. And again, ongoing monitoring and reassessment. You are still you still need to know about you still need to know all the other assessment tools that you can use and how to use them, because actually that's part of monitoring. And you're right, we do. People get, and it's like I was saying about, the trust was saying, why are they doing an essay on assessment? Well, because they need to know how to reassess somebody. They've got to understand how to use a must tool effectively, how to perform a pain assessment
all that
effectively.
kind of stuff. Yeah.
SBAR. I love SBAR.
I love the mental health part of it, yeah.
You've got to know how to use it properly in order to be able to work effectively with colleagues.
And it is, and I said, even when nurses would do for wounds, for example, if a new patient turns up, the nurse or a doctor would do that first assessment. I have no issue with that. But for me, when I see them next, something might have changed. I might now look at this and go, actually, it wasn't infected before, and now I feel as though it is. So where do I go from that? And knowing the signs,
and you can recognise
exactly.
Yeah. Because you've done your AMP that tells you, actually, when there's an infection, this is how the skin reacts. And so you're looking for redness, you're looking for other signs of infection. You're going to be talking to the patient. It's you've got to be able to do that. That's really important. Brilliant.
So obviously with advice and stuff like that. So what advice would you give to someone that's currently training as a nursing associate?
Okay. We looked at this in 2 ways. So we got currently training and then trained.
Yeah.
So take advantage of every single learning opportunity, okay? And don't wait for it to land on your plate, because it's not going to happen. Doesn't happen with student nurses. It's not going to happen with student nursing associates. You need to be really proactive. Put yourself out there. I want to do this. I want to learn. You're going to get knockbacks. You're going to get the nurse who goes, oh, no, I haven't got time. What I want to get across as well is that is not just student nursing associates that happens to. Student nurses get the pushback all the time as well. They're still being told, I haven't got time, I can't do this. I have student nurses who will say to me, I'm treated like an HCA. It's not just the nursing associate students that happens to, but I think it happens more to them. And I think part of the problem is, and I'm really keen to push through the idea that when you put on a course, you change area. Because when you've been working as an HCA, even if it's only been for a year, you are known in that area as an HCA. So when you transition and suddenly you're an apprentice, nobody sees you as an apprentice. They see you as an HCA. And it's constantly having to put that hat on. And I get so frustrated when people say, oh, well, I'm in my HCA role today. No, you're never in an HCA role. You are an apprentice. The sheer nature of being an apprentice means you are learning 24 all the time you're at work. You are learning. You should not be thinking HCA role, nursing associate role. I know there are people that do. And it was one of the things when I was at Chichester that I said, no, I really want nursing associates in just a university uniform with nursing associate apprenticeship written on it, because people need to acknowledge that student status. Whether you're a nursing associate or a nurse, registered, student, you're a student. You are learning. And I think all the while people are going off to work in their old HCA uniform, and they're being told, well, you're in the HCA numbers today. That's a financial thing. That's not anything to do with the apprenticeship. It's purely because they can't put them into the registered nurse numbers, because they're not a registered nurse. They have to sit the HCA numbers. And I think as student nursing associates, you really need to be pushing that rhetoric. I am a student. I am a learner. I am on an apprenticeship. I need to be learning. I need to be doing this. Yes, you have to do your substantive role, because that's part of being an apprentice. But it's finding those opportunities. It's having those conversations. I was talking about the theory hours with some students, and they really couldn't get their head around, and actually practice couldn't either, about, well, what's a theory hour? How do I get my theory hours? Because let's face it, as an apprentice, you do not get the number of theory hours you need from your 1 day a week at university over 2 years. So you have got to do some theory when you are at work. So what's a theory hour? Well, you do a wound dressing. Actually doing the dressing is practice. But going away and having that theoretical conversation about why you changed the dressing from X to Z, that's theory. That's looking at the research behind it. And I think it's really important for student nursing associates to understand that, they are constantly learning. And so they need to be asking questions, not just let it go. Ask questions. Ask the doctors. I had one student she was in the emergency department, and she had a fantastic conversation with the doctors about why they'd changed from one cardiovascular drug to another. And he was so happy to talk to her into professional working.
I always said it'd always be that 2-year-old and ask the question, why?
Yeah, why? Yeah.
Why are we doing this?
Critical thinking, why?
Yeah.
Why,
and like
why,
I said,
why,
it's
why?
not because, like I said, you're being, pedantic or anything like that, or you're trying to annoy them. It's just because you are generally want to know how they made that decision. How did you get to that point where you thought, this is the best option, this is the route we need to go to? Because that is, like I said, that's going to
Why have we
help
gone
you
down that care route?
understand. Yeah, like I said, you may become a doctor one day, which would be fantastic. But for me, like I said, I didn't want to be. So it's like, knowing how they've made those decisions is great to understand that they're thinking. And when they make those decisions again, you go, oh, this is the reason why. This is what they've done it. I just want to go back to another question, which is you've spoken about wanting to kind of bring more recognition and respect for the NA role. So what needs to change nationally, do you think, to kind of make this happen?
That's a really difficult one.
And
I'll talk from my own experience on that. I'm a school nurse. When I went to the public health conference back in, we are talking a few years ago now, it was 2010, there was 1,800 of us in the country. If you think about the number of school children there are, 1,800 is not a lot of qualified school nurses. We're the minority. So I really feel for nursing associates, because actually I feel like we've been banging the drum for school nursing for so long. But it is about getting people in power to recognise and to listen and to hear. And I know you're doing a great job in actually getting the voice out there, but actually it needs more of us, and it needs the qualified, not qualified, that sounds really awful, the registered nurses to be banging that drum as well, and actually to be going, no, this is a really important role. I need this role. I need nursing associates on my team. I need to have nursing associates working on the wards if you're the matron, because actually they are valuable. They are freeing up my registered nurses to be doing the really complex care. We're not having to constantly rely on calling doctors in because I don't have enough staff. It needs to be top down, and it's got to be driven by government. It's the issue we had within public health when we had the call for health visiting, which was fantastic. Now, very, very sad. David Cameron had a child with significant disabilities, and that in itself was really sad. But that drove that call for health visiting, and it drove people coming into health visiting. So as school nurses, you can't help but think in the back of your mind, when he gets to school, they're going to see the value of school nursing. Very, very sadly, their child died. They never got to school age. It all petered. The drive for health visiting sort of went, and it petered. And people weren't recognising it's all very well bringing all these people into health visiting. You're not taking into account all of those that are dropping off at the other end. It's very well bringing, and we kept being told, school nursing, that's local. Local government are driving that. No, they weren't.
Yeah.
Local government weren't interested. So it is about getting the right stakeholders involved. And the right stakeholders are our MPs, are our top NHS professionals. Getting doctors, sort of senior doctors involved, because they're invested in what's happening on their wards. They want the proper care. They want right care for their patients. It is a really difficult one. And I think it is about a united voice from all of us. We've got to stop the in-house bickering about, the nursing associates, they're just cheap band fives, or, they're coming in to steal my job. I want a band 5 job and they're coming in to steal. We have got to stop that. We are all nurses. Yes, some of us are classed as a registered nurse, and some of us are a registered nursing associate. But at the end of the day, we are all nurses, and we are all there to care for our patients, to look after them, to look after the public. We've got to stop the in-house bickering, and we've got to start pulling together. We need more integrated learning. So we need to have that understanding. We need to be training interprofessional learning. So where you've got all the fields of nursing are coming together with physio, with occupational health, with dietitians. So everyone is learning off each other, but then people are still seeing within nursing, we've got adult children, mental health, learning disabilities, and we have nursing associates, and they are part of the nursing family. And I think until we stop that in-house bickering that goes on, and it is so sad when people say, I hear people say, oh, it's a nursing associate, or well, they're no good. Some of the best care I've had as a patient has been from nursing associates. It's been fantastic. And no one of them who I met, she was absolutely lovely. And she wasn't looking after me, she was actually looking after my husband. And we had a really good chat. And she is going on to do her top up. Don't call her top up, that's wrong. But she is going on to become a registered nurse.
Yeah.
And it's fantastic. She is excellent, brilliant. She's going to add to the pool of Band 5s, but we still need nursing associates. And we need to have that recognition. I think registered nurses have to drive that, because we have got to start supporting you, and we've got to start saying, actually, no, this is valuable. I need you, because you are doing a really incredible job and taking so much off the registered nurse without taking away from the registered nurse. And I think that's the bit they miss. You're taking it off them, you're not taking it away from them.
No, that's brilliant advice. Right, so before we wrap up, I've got two kind of quick final questions really for you. So the one is going to be around the final message you'd like to leave to our listeners today. But before we do that, we always get our guests to give us a song that we can add to our SNA and RNA playlist. This is to help our nursing associates who might be doing their kind of fourth long night shift or getting ready for a very long day of hecticness and stuff like that. So what kind of song can we add to that playlist for you?
So I'm terrible. I'm an absolute Queen fan. So do you know what? You can go Under Pressure, because that is what you are. And that is what we are as nurses as well. You know, we're all nurses are under pressure. And I just think it's brilliant. It's upbeat, and it will just, yeah. I like it as a song. And I think the words
very, 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 very much so. And do you know what's quite cool? I've actually got an LP player here, and actually what's actually on my LP is actually Queen. So it just works out perfectly. Yeah. So it's meant to be. Right. So like I said, my last question, like I said, is really much kind of like, what kind of message would you like to leave to our listeners today?
Be proud of what you're doing. Okay. Be proud of what you're doing, what you're achieving. Don't let other people pull you down. Shine your light, because actually the nursing associate role is fantastic. Be proud of what you're bringing to the nursing family. You know, nursing is tough. It's a hard profession. Anyone who says it's easy doesn't know what nursing is. But just be proud. Be proud of who you are, what you are, and just shine. Because actually, you know, it's a fantastic role.
Brilliant words of advice there. Absolutely fantastic. And Charlie, thank you so much for joining us on Just a Sharp Scratch.
Thank you for having me.
And for our listeners, I'd like, if you'd like to own a copy of that Clinical Pocket reference for nursing associates, it's packed with guidance across all 4 fields of nursing. So key clinical skills, practical tips for placements and daily practice. There's a special, like I said, exclusive offer for all students or nursing associates and even registered nursing associates. So like I said, if you look at the link below, we'll give you all the information and that special code that you'll need. And don't forget to subscribe on Spotify, Apple, or wherever you get your podcast from. Until then, we'll see you next time.